Well, hello. Thanks so much for joining for episode number 13 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hockman. I hope you had a great Thanksgiving and maybe even were able to spend a little bit of time with family, whether that be socially distanced or in a virtual fashion. So as we head into the holiday season, we are reaching a critical point with the coronavirus pandemic. Rates are starting to rise. So I thought we would devote today's episode to going back to the basics, Coronavirus 101. My guest today is quite literally the person who wrote the textbook on managing coronavirus in the outpatient setting. Dr. Pieter Cohen is a primary care doctor at the Cambridge Health Alliance and Harvard Medical School. He's also probably the world's expert in dietary supplements and the harms associated with these supplements. And we will definitely have Pieter back to talk about this topic in more detail. But in addition, Pieter also happens to have written, be the lead author on the main ambulatory chapter on managing coronavirus for ambulatory patients in UpToDate, which is the most popular medical textbook. Pieter and I have a long history together. He was my main mentor during my medical training, my residency program, also at the Cambridge Health Alliance. He and I wrote a blog together for 5 years called Updates in Slow Medicine, which is really the precursor to the Healthy Skeptic MD podcast. The theme of slow medicine is very similar to Healthy Skeptic MD, less is more. Pieter's also a wonderful person, a great friend of mine. So happy to have him on the show today. I'm going to skip over the news summary of the week to make sure that we have adequate time for the interview because it is excellent. But if you do like what you hear today, please do search and subscribe to the Healthy Skeptic MD wherever it is that you listen to podcasts or for the Healthy Skeptic MD channel on YouTube. Let's dive right into the interview with Pieter now. Well, welcome to the Healthy Skeptic MD, Pieter. It's great to have you join me today.
Mike, thanks so much for having me. It's my pleasure.
Well, it's a real pleasure and honor to have you here today. So let's start at the beginning. Back in February or March, we heard about the novel coronavirus and there were some cases in Asia. When did you start to realize the magnitude of what we were dealing with here?
Well, I have to say I was a little slow on the uptake, honestly. In February or so, my wife asked me, what's the deal? Should we be worried about this? We've been reading about this. And I said, it's not to be worried about. It's nothing to worry about. I'd seen so many of these in recent years. Ebola had seemed to reach New York City even in an aid worker just a few years ago. Of course, SARS and H1N1. And every time it seemed like it was not as serious a threat as we had first worried about, or we were able to stop it at some point before it really swept over the states. So I had presumed in February that we were in the same situation. It wasn't until March, and business seemed to be as usual in Cambridge, walking around in Harvard Square, Central Square. People were out at restaurants, chatting, hanging out. That day, every day after that, things were dramatically changing. And within 10 days, I'd be working full time in our COVID clinic, which our healthcare system set up to handle the surge here in Boston.
Well, I have to admit, I was also a bit slow on the uptake. It definitely took me until mid-March to realize what we were dealing with here. You mentioned that you jumped right in and started working in the COVID unit at the Cambridge Health Alliance, which is a major public safety net system in Eastern Massachusetts, right outside of Boston. Could you just tell us a little bit about what the setup is like there?
So, of course, most of us are thinking about COVID care being in hospitalized patients. And of course, the sickest patients are hospitalized. They're intubated and need help breathing. But most of the patients, as we know now, can avoid hospitalization. Because there was a stay-at-home order in Massachusetts and all non-essential medical care stopped for 2 months. During that time period, the ambulatory clinics had no role, so they were all shut. Except one was opened just to take care of those moderately ill patients suffering from COVID-19 who weren't sick enough to require inpatient hospital care, but really needed physicians, clinicians to be caring for them, sometimes on a day-to-day basis, or maybe just once a week. But that's where I went to work. So we had a big, excellent, amazing team of people who came together from all the different clinics in our healthcare system to work in this setting.
Right. Well, that clinic has received a lot of attention and appropriate recognition. And in fact, I think that's probably how it came about that you ended up being asked to write one of the main chapters in the main medical textbook on the ambulatory management of COVID. So, hats off to you all at the Cambridge Health Alliance for rolling up your sleeve and digging in and figuring out how to keep people safe out of the hospital. So one medical question that's perplexed me as a primary care doctor is the amount of variability that happens with this disease. I've had one patient who's died. I've had a couple others who have been hospitalized. And then I've had a couple others who have hardly even known they're sick at all. Do you have any sense for why that is happening?
Yeah. Well, first of all, one thing to remember is that while in our sort of imagination, we generally think of illnesses as being, we know that the common cold, for example, mild. We think of cancer or tuberculosis, deadly. But in reality, almost everything we treat, there's a wide range. It's very, very exceptional when illnesses are universally fatal. Ebola is a dramatic example of really the unusual situation in which it's fatal, or HIV was before treatment was found. So the norm, whether or not we're talking about tuberculosis or prostate cancer, as you often discuss here on your podcast, is that there's a wide range of spectrum presentations, a spectrum of illness. And many people can have tuberculosis, can have prostate cancer, and have no untoward effects or not even notice it really if they didn't have testing. And that's really the same for this virus. SARS-CoV-2 can cause absolutely no symptoms or just a runny nose. And for other patients, it can cause very severe disease.
Well, I think the prostate cancer analogy is a good one because there is so much variability in that and many other diseases. I think that's what's so deceptive for people about coronavirus is because, 98 out of 100 are going to do quite well with it, but 2 people can get life-threateningly ill, which makes it a very dangerous situation. So, Pieter, as we're heading into the fall season here, we are clearly seeing, unfortunately, an uptick in rates, presumably from people spending more time indoors and other various factors related to the fall season, the holidays. How worried are you about what the next few months has in store for us?
Oh, I'm extremely worried, Mike. I think we're heading into a very difficult time. Really, the key to transmission is, in addition to the mask wearing, the quarantining when you're ill or diagnosed, rapid testing, and all those other things, it's when we do have those social interactions to be outside. The ventilation outside is just tremendous. I love the outdoors, and I know you do too. And, there's no better place to be during the pandemic than outside and spending time with our friends and loved ones.
Well, we're here in Los Angeles. We're very fortunate where the weather is a little milder or substantially milder than it is on the East Coast. So I've been telling my patients to really take advantage of that and wear long sleeves, but get outside when you're seeing others. I think in the East Coast, you don't necessarily have that luxury. So, we're really hoping for the best and keep windows open and anything that gets the air circulating when you're not able to go outside. So Pieter, again, you literally wrote the textbook for ambulatory management of coronavirus as we're heading into this fall surge season. Give us the 101. Tell us, how does coronavirus present? What should people be looking for?
So it could be at the start. It can be any symptom whatsoever. So again, as we mentioned, it could be that you have no symptoms whatsoever, but it also could be that you have a runny nose or sore throat, something like the common cold or something that similar to strep throat. Other people develop maybe a bronchitis, a cough, fever, something like a pneumonia, and other people have abdominal pain or diarrhea. One of the early clues to the diagnosis is a change in smell or taste. That should really, the only thing you should think about is getting tested and being quarantined if you do lose your sense of smell these days. Aside from that, it really overlaps with all sorts of common ailments. And that's why it's so important, if you have any symptoms, get tested, and to not go to work and to self-isolate even from your family. We do think that wearing masks and staying isolated, even in your own home, could decrease spread. So we definitely encourage that. When the virus becomes a more serious illness, the tip-off will be a few days later. So we're talking usually between 4 to 8 days after those initial symptoms have begun, that people will start developing different symptoms. And the difference usually involves some difficulty breathing. Sometimes it could be dizziness. And this might get worse if you're trying to do chores around the house. So that first stage, the emphasis should be getting tested, isolating, wearing a mask, being quarantined. The second phase, if you start experiencing those new symptoms, especially 4 to 8 days after you were initially ill, that's when you need to talk to a doctor. Start off on the phone and decide if you need to be seen.
Peter, I read a couple of your articles about coronavirus, and you've made a distinction between that shortness of breath that you might experience early in the illness, maybe from anxiety, from being infected, with that more serious shortness of breath that you experience a few days later. How do people tell the difference, and how do they know when to worry?
So it's common when we're worried to have other symptoms. And one of the common symptoms with anxiety is difficulty breathing. But the way that's experienced is a little bit different. It might give us some clues if we're experiencing difficulty breathing because of anxiety or because the virus is affecting our lungs. Some of the clues that seem to work for us in clinic are that if it's anxiety, the sensation will be that it's a sense that it's hard to fill up your lungs. So someone might take a deep breath, but have a sensation that their lungs are not filling. That's not uncommon when people are experiencing shortness of breath from anxiety. Now, if you ask someone with anxiety if they're able to walk around and to do their normal chores or go up a few flights of stairs, they might very well feel that there's absolutely no difference. They feel comfortable doing that. But when they sit down or they're trying to sleep at night, they're having trouble getting air into their breath. That would be classic anxiety. If the virus is affecting the lungs, the more strain we're putting on the lungs, the more we try to help out around the house, do dishes, go up a flight of stairs, the worse the breathing's going to get.
Yeah, so I think that's a really important point. It's also what I've been telling my patients. The minor shortness of breath that you feel associated with anxiety is very different from the shortness of breath that you might feel with exertion, as you said, when doing chores around the house, when walking. If the symptoms get worse when you exert yourself, that's more concerning than if they improve when that happens.
The only thing, Mike, is that I wouldn't necessarily describe it all as minor shortness of breath. During a panic attack, for example, you could have, it could almost be like you are suffocating, you cannot breathe, and you're going to pass out because you can't breathe. So the sensation of dyspnea can be dramatic in anxiety. And with that, I think it's worthy to point out, there are some situations that the virus, the virus is affecting the lungs and the oxygen level is dipping, but people don't experience any shortness of breath. So that's a minority of patients, but that's also out there, that this virus can do that.
So Peter, you just mentioned that issue about the oxygen level dropping. Maybe you don't even necessarily have shortness of breath. It's not a common situation, but it can happen. There's been a lot of interest in giving people home oxygen monitors to wear on their fingers to make sure that that's not happening. What's your take on that?
So the question is, do you need one of those? Should you have it? Could you prevent harm? And there's been a school of thought that says that's like life-saving. Make sure that everyone has these high-quality monitors and will save lives. In my experience, that's unfortunately not the case. We actually took a look at this in our clinic, and we did a quality improvement study in which, because we had so many people during the surge who had trouble breathing, but we only had 50 high-quality of these home monitors. So instead of just giving it to the first 50 people, we randomized people to either get them or not get them, so we could try to get a sense if they were actually helping. I was actually concerned. What we found among our small group of patients who got it and didn't get it was that there was no difference, fortunately, between people, how many emergency department visits there were. There wasn't any difference between hospitalizations. There wasn't any difference in visits, clinic visits. But what was a bit concerning, just a little bit, because it's preliminary, was that we had more people who required a breathing machine, a ventilator, in the group who were given the home oxygen measurement. So this at first just seems like a quirk, a weird chance. Like, how could it possibly be that giving someone an oxygen monitor could lead you to be intubated as a cause and effect? That makes no sense. But, the more we thought about it, we thought there could be some connection. It's possible. And here's how one thing we worry about. What if the oxygen monitors give both the family and the patient a false sense of security? So we have had patients who are getting really sick. They're having trouble breathing. They're breathing very fast. They don't look well, but their oxygen level is still, let's say, 94, 95%, which, they would have been told, and 95 is normal. 94 is practically normal. So those patients might not go to the emergency room early enough to get the help they need. But my take home right now, Mike, on home monitoring is that it's not necessary. You don't have to panic if you don't have access to one. It's much more important putting the whole picture together with your doctor. But if you do have a home monitor, make sure that you don't overly rely on it. And if you're feeling worse, or if your loved one's feeling worse, even if the numbers look good, make sure you're calling your doctor and explaining that you feel worse and that you want to be seen.
Yeah, I think that is exactly right. It's certainly my perspective as well. The oxygen level is just one piece of information. There's so many other factors, many of them more important, such as how does the person look or feel, how hard are they working to breathe, that we should all need to consider. And the risk with the monitors that we over rely on that one number, and it can sometimes lead us astray. So Pieter, if it's okay with you, I'm going to ask you a couple questions that I've just been getting from my patients. A lot of these are sort of gray, that may not have a right or wrong answer, but I get them all the time, and I'm sure many of the listeners have these questions as well. So we'd love to get your take on it. One question I get all the time: okay, I've got the sniffles. Why do I need to go out and get tested? I don't want to go in and expose myself.
Well, with the exception of if you need to take public transportation to get tested, I would strongly recommend testing. It's a really powerful, it's a very powerful finding when you actually find out that you're positive, that you have the virus. That leads to a dramatic difference in terms of not only your likely willingness to stay at home and self-quarantine for the requisite days, but also to go and think very, very carefully, who have I been with for the last 5 days? Who have I spent time with? Calling them, making sure they know, and having them tested. And we should point out, Mike, that testing is not perfect, of course, and there are many cases, we don't know what percentage, but certainly cases in which the test is going to be negative, but the patient actually has the virus.
Great, very helpful information. So here's another question that actually is relevant to your day job in the pre-coronavirus times that I've been getting a lot from my patients. What about vitamins and supplements? There's been a lot of interest in vitamin D, vitamin C, and zinc for reducing your risk of getting coronavirus. What's your take on all those supplements?
Well, there's a lot of research. At present, there's only preliminary evidence that might suggest some hypotheses, and nothing to convince me at present that one could decrease the risk of either getting COVID-19 or getting a severe case of it by using any of these over-the-counter supplements or vitamins. That's not to say that won't be the case. There's a very rapidly evolving field, and I look forward to anything, regardless if it's a a vitamin or a brand new drug that can help us deal with this illness.
Yeah, well, that's been very similar to my answer for the patient, to patients as well. I just right now, there's not the evidence to hang your hat on. I can't tell you with any degree of certainty that these vitamin D, zinc, vitamin C will help you. So, certainly not a necessity that everyone rush out and get them. Another question, if you do get diagnosed with COVID and you have relatively mild symptoms and you're being treated at home, what simple things can you do to help yourself recover faster?
The key is going to be staying well hydrated, eating well, as healthy as possible. That's really the biggest challenge sometimes, because people tend to many people lose their sense of smell or taste, appetite, and just being ill. The appetite really goes out. And the last thing we want is that while your lungs aren't getting sicker because of the virus, but because you haven't had anything much to eat for 3 or 4 days, you're passing out, or you're getting too dizzy to walk. The other thing is, and this is in quite serious cases when the virus is getting into the lungs, but there are some techniques that can make it a little easier to breathe. Now, this would only be after speaking to your doctor, but sometimes lying on your stomach can really help people at night breathe a little easier. So there are some simple maneuvers at home that can help.
The fluids is a really important point. Do you recommend straight water, ginger ale, or Pedialyte? What do you recommend for liquids?
Yeah, well, it's going to depend on whether or not you're able to eat. So I would really encourage people to be eating too. If you can have soup or other foods, then water's great. But if you're unable, the only thing you're going to be able to do for a given day or two is just drink, then it's wise to move to something that's a little more balanced in terms of electrolytes.
So, Peter, the holiday season is approaching. There's a lot of people who haven't seen their family in other states for a while. There's a lot of interest in getting on a plane and going to visit them. How safe is flying right now?
Well, the thing is, Mike, I'm very hesitant to be in any setting when I'm indoors with other people with a time I can't control. So it's not just being on the plane, and I understand that ventilation in the planes are quite good. It's all the other steps that are involved. How do you get to the airport? How do you make sure there's enough space at all times between you and other people, that things are moving around? To me, that all is of great concern. So I personally, while I go in and take care of patients with COVID-19 every day in clinic, when I'm working at our COVID clinic, I am not getting on a plane for the holidays, and I'm advising my loved ones not to get on a plane for the holidays.
And I assume the same would apply to indoor restaurants?
Indoor dining, yes, I'm not a fan of. So outdoor dining is really what I am very comfortable with. You're outside, there's air blowing in, that's fantastic. And it's a great way to support the restaurants and get out of the house. And with heat lamps and other ways to stay warm at the restaurants, hopefully that will last throughout the winter. It's still very prominent here in Boston. But going inside to eat with other people concerns me. We know there's evidence that the virus can be spread from people sitting at one table to people sitting at the next table. That concerns me. So to me, in my family, we have a no eating inside policy.
Yeah, well, it sounds very similar to our policies as well. We certainly have not been doing any indoor dining. I have not been on a plane since the pandemic began in March, and I certainly wouldn't do so unless I absolutely had to. And if I did, I would certainly take all the precautions and be very careful and mitigate those risks as much as could be possible. One other question, if someone does have to travel, there's a true emergency, they do have to get on a plane, what do you think about getting tested before they get on the flight?
Well, I think that I think that's very responsible from the perspective of not wanting to be known positive and hop on a flight. So in terms of being a responsible citizen, that's terrific. But that doesn't mitigate the risk flying, to either spreading it or getting it entirely.
Yeah, I agree. I think that's also where the false sense of security comes into play. I think the last thing we want to do is have a negative test and just assume that means we're safe and we're not infectious to others. So I think it's there's no reason not to get tested, and if it's positive, that's helpful. But if it's negative, that does not mean you can let your guard down. Is the message that I've been trying to give.
Completely agree, Mike.
When patients do get admitted to the hospital, there's been a lot of different treatments that have been proposed: remdesivir, a steroid called dexamethasone, a monoclonal antibody. Which of these treatments actually has evidence now to support effectiveness?
Well, I think that the far and away, the treatment that has the most evidence is a steroid. So the dexamethasone, probably other steroids that are like dexamethasone, actually saves lives. So there's been a number of studies that have been consistent, suggesting that not only does it help mitigate some of the symptoms, but also can decrease deaths. Remdesivir is a different situation. There is evidence it's approved by the FDA for treating COVID-19 in the hospitalized patients. There is evidence that works, but it's not consistent from study to study. So while there might be a study that shows it has benefit, and the benefit is not dramatic. It's not saving lives so much as decreasing the time one needs to spend in the hospital, which is not insignificant, of course. But if you see that in one study, but then don't see in the next, it raises questions. The thing about remdesivir, it's much more expensive. Access to it is much harder to get than dexamethasone, which is inexpensive and easily accessible at any hospital. So don't panic if you don't have access to remdesivir. It's not a lifesaver. Monoclonal antibodies are an area where the FDA just gave emergency approval for one, but to me, they jumped the gun. There's just not the level of evidence that we need to be able to say, this is going to be effective to treat this illness.
Well, I completely agree with your take on the different treatments. The only thing I might add is that I even think the FDA may have jumped the gun a bit on remdesivir, not providing the emergency use authorization, but actually giving the formal stamp of approval. I think that may reduce the incentive to continue to do the studies to iron out some of these discrepancies between the different findings. So I might have voted to keep it in that emergency use authorization status rather than to give it the full stamp of approval. But I agree completely with your perspective.
Oh, no, Mike, I totally agree with you. And about remdesivir, I think that if they had decided to approve it, they should have done it for a very explicitly narrow group of patients. So patients who were hospitalized patients with COVID-19 on what we would call low flow oxygen. That's a very, very specific group. If they had approved it for that group, I would think that would be reasonable. Instead, my understanding is that they have approved it for treating COVID-19 in hospitalized patients, which is, we have a lot of evidence that that's not going to help all those patients.
Yeah, well, I completely agree. So, Peter, I have two final questions for you. The last couple of weeks, we've gotten some very encouraging evidence about the vaccines, that they're 90+, maybe 90+% effective. The piece that I'm still a little anxious about is safety. We just have not had those months and months and even years of data to track any unanticipated side effects. How will you feel comfortable that these vaccines will be safe?
Well, I guess I have a different concern, Mike. Safety, for me, what comforts me a little bit about the safety is that while I agree with you, we don't have the long-term, multi-year thing. What I've been struck by is how many people are in these trials, are enrolled in these trials. So from a safety perspective, to me, that's reassuring that we're really having tens of thousands of people that are going to be exposed to these vaccines prior to the FDA even considering whether or not they should be approved. What I'm concerned about is that the way that this could somehow be seen as a magic bullet that is going to stop this pandemic, that somehow we can let our guard down, either now or in a few months when the first people are getting vaccinated. This vaccine, no matter how effective it is, given the complexities of rolling it out, of enough people accepting it for it to really have any effect on community spread, I think is the real challenge right now. The challenge I'm worried about is that we're going to have our behavior is going to get even worse as a community or as a nation. And that behavior is going to so outweigh the benefits of the vaccine coming in. So it creates this false sense of security. So that's really what I'm worried about, rather than the safety of the actual vaccine.
Yeah, I think it's a really important perspective for people to hear, that a vaccine is not a replacement for doing all those other things. And that's actually a nice lead into the final question I had for you. As we head into the holiday season, what advice do you have for your patients and the general lay public?
Well, I think the thing is to realize that this is not the time to let down your guard. Rather, it's an opportunity to really re-envision how we're spending time. So, I have teenagers here in Boston who are sitting out in the backyard around a fire pit to spend time with their friends. This is the sort of reimagining of what we can do, how we can communicate, how we can use technology to communicate, and we can be outside for walks, even on the coldest days of the year together. So this is the time we unfortunately have to buckle down, rather than letting our guard down and start thinking about there's light at the end of the tunnel from vaccines or anything else.
Well, I like that as a closing note. It's time to buckle down, but we can be creative and figure out ways like sitting around a fire pit where we can get some of that social interaction in a safer way. Well, Pieter, thank you so much for joining me today. Pieter Cohen from the Cambridge Health Alliance and Harvard Medical School, author of the main coronavirus management chapter in ambulatory care for coronavirus in the main medical textbook that many of us doctors use, UpToDate. Thank you for joining me today. If you do like what you hear today, please do search and subscribe to the Healthy Skeptic MD, wherever it is that you listen to podcasts and on YouTube. We'll pick it up again next week. Thank you.